All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound Case Series. This week we have Dr. Logan Wilz. Dr. Wilz completed his family medicine residency at the University of Iowa after completing medical school at the University of Wisconsin. He's currently a fellow at the University of Iowa in primary care sports medicine, and he will be presenting today on EHL tendinosis. All right, Logan, you're free to share.
All right, thank you.
Looks good.
Can everybody hear me?
Yep.
Perfect. So good morning, everyone. As Dr. Betcher mentioned, I'm Logan. I'm one of the primary care sports fellows at the University of Iowa. And today we'll be going through a case of extensor hallucis longus tendinosis. I do not have any disclosures. I will note most of the anatomy slides are here. I took from the Complete Anatomy app. Again, no disclosures to that, but it's been pretty helpful this year for as a good anatomic reference for learning different structures and things like that throughout the year. Our outline today will review the protocols recommended by the AMSSM Sports Ultrasound curriculum for complete sonographic evaluation of the anterior ankle and leg. Using a patient case, we'll demonstrate normal and pathologic sonographic findings in this region. And then we'll overview the diagnostic ultrasound report for the presented case. We'll start just by looking at what that AMSSM recommended protocol structure identification list is. On the required list, you have the 4 anterior leg compartment muscles and tendons, including the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and the peroneus or fibularis tertius, the anterior tibio-talar joint and talar dome cartilage, sinus tarsi, the AITFL with the dynamic assessment is indicated, the superficial fibular nerve from where it exits the crural fascia down into its division into the medial intermediate dorsal cutaneous nerves, and then the deep fibular nerve and the distal anterior tibial artery and dorsalis pedis artery. There are 2 optional structures also on the anterior leg and ankle. And that includes dynamic assessment for anterior impingement, and then visualization of the extensor retinaculi, of which there are superior and inferior across the anterior ankle. Neither of those were imaged in this patient. So getting into our case, we have a 62-year-old female who's presenting with atraumatic left dorsal foot and ankle pain. She has had progressively worsening pain over the past few months, and now all weight-bearing activities worsen the pain. The pain is not improved with physical therapy, and therefore she was referred to us for ultrasound. On exam, she's focally tender, overlying the EHL at the level of the ankle joint and extending just distally towards the midfoot. Pain is reproduced with resisted first toe extension, and then complete exam of the foot and ankle was otherwise unremarkable. We did get some standing films of the foot and ankle. These are just some representative pictures, but overall, those were unremarkable. Didn't show any acute fracture or dislocation. Mortise was intact. Anterior joints looked good. There were no osteophytes, no loose bodies, no evidence of kind of dorsal midfoot exostosis or anything else that would potentially be causing to raise concern for other etiologies of issue in this area. Before we get into the scan, our ultrasound setup, so our patient was positioned supine with the plantar surface of her left foot flat on the exam table in a slightly plantar flex position. Again, we did a complete anterior ankle and leg examination, and then we were using Canon Aplio i800 ultrasound cart with a combination of a 24 megahertz ultra high frequency linear array transducer and the 18.5 megahertz linear array transducer. So starting the scan, we'll start at the anterior tibio-talar joint in a long axis. This is, you're going to be your most sensitive position and location to look for things such as effusion and other joint pathologies. And just to note, you want to make sure, even if you start more central anteromedial like this, scan the entire width of the talar dome cartilage, and that'll help you not miss anything on your evaluation. So here, use the hyperechoic bony landmarks of the tibia and talus to help orient yourself. There's a hyperechoic fat pad that will sit in between them. Deep to that, not the best visualized in this photo, which I guess could be a good thing, but you have your anterior synovial recess. So there can be a little bit of a few millimeters of physiologic fluid in this area. So don't overcall an effusion there, but certainly keep an eye out for it. And then also don't overcall the hyaline cartilage here of the talar dome as a synovial effusion either. So normally there's a few millimeters of thickness in that region. This should appear pretty anechoic and be uniform in thickness. You can pick up things like OCDs and other cartilage injuries. If you're concerned that you may be missing something, putting the patient in a plantar flex position can help expose some of the more posterior middle part of the talar dome cartilage. But kind of one of the caveats of ultrasound is you're not going to be able to see kind of fully into the joint there. Let's see here. And down here, as we go, we'll try to highlight a little bit of the report that we'll go over at the end. But here we see the anterior tibio-talar joint shows no significant degenerative change, synovial abnormalities, or effusion. And last point to make here, again, we didn't do that in this patient, but you can look for anterior ankle impingement in this area by doing a dynamic scan, placing the patient in dorsiflexion. Rotating into a transverse view or short axis view of the tibio-talar joint, you get a really good view of the entire width of the talar dome cartilage here. Again, we see uniform thickness, a few millimeters, and no kind of focal cartilage defects missing. And same with kind of the underlying talus, there's no bony abnormalities there. After looking and fully evaluating the anterior tibio-talar joint, then we'll move into the anterior ankle tendons. And I'll typically scan these working from medial out to lateral. So the first tendon that we will encounter are the tibialis anterior tendon and muscle. So these will typically start scanning at the level of the ankle joint. In short axis, scan distally down to its insertion, and then proximally up into the usually the distal aspect of the muscle belly. If there's concern for more proximal pathology, you can certainly scan the full muscle length up into its origin. But I would say if they have pretty clear localized foot and ankle pain, that isn't always necessary. And then from there, before moving on to the next tendon, we'll do the same thing in long axis of that view. So the tibialis anterior, this is the largest tendon we see here of the four extensor tendons of the ankle across the ankle joint. It's got a fibular hyperechoic echo texture and overall appears normal here. We don't see any Doppler flow through it. And then again, not imaged here, but scanning up into the distal muscle, the appearance is normal and there's no evidence of tendinosis or tear. If you do have difficulty finding this, kind of tilting or wagging your transducer to create some artificial anisotropy can help make the tendon more conspicuous relative to the surrounding soft tissue. You can also have the patient dorsiflex their ankle and help keep their toes in more of a neutral position to kind of clinically be able to palpate this. In this area, this is the most common anterior ankle tendon to be injured. Most of the tears will occur within 3 centimeters of its insertion, so in between there and the extensor retinaculum. This tendon can have some variable insertion. So most commonly, you'll see a longitudinal split tear with a slip going to the base of the first metatarsal and to the base of the medial cuneiform. And then that can be differentiated from true tendon pathology by assessing for pain, looking for Doppler flow in that area, and also just kind of being a characteristic location. And then rotating into a long axis view of the tendon, we see across here, again, normal appearing tendon, hyperechoic fibular echotexture, and the soft tissue below, and you can kind of see the makeout of the ankle joint down there. Again, in this view, there was no Doppler, and scanning into the muscle belly, things appeared normal. Moving laterally to the next tendon, we see the extensor hallucis longus tendon back in short axis view at the level of the tibio-talar joint. So that is here. And we see it to be significantly thickened and appears very hypoechoic, especially compared to our last tendon and the others, and is more heterogeneous echotexture to it. And this is again at the level of the tibio-talar joint. You can see the cartilage below there. At this point, we kind of switched down to the 24 megahertz transducer to get a little bit of a more fine view of the tendon. Again, we don't see any large tearing to it, but you definitely see that it's hypoechoic and fairly heterogeneous in its appearance. We do put color Doppler on it and see a moderate amount of intertendinous Doppler throughout the region. Rotating into long axis back at the level of the tibio-talar joint, you start to see this transition from a fairly normal tendon appearance where it starts to get thickened, becomes again more hypoechoic and overall swollen. We then put Doppler onto this area, and again re-demonstrated as more of a moderate level of intratendinous Doppler, continues thickened, and this is followed, the thickened portion is followed from a distance, proximal and distal, of about 1.2 centimeters. So this is good. It's always good to confirm intratendinous Doppler into two orthogonal planes. And then this slide here, we look at just the contralateral side for comparison. This is the distal insertion down on the distal phalanx. So the right foot didn't have pictures kind of correlating from the other side of the region of pathology, but normal tendon appearance here is, of course, is the IP joint and inserts. So this is a good, I guess, view or location. Again, kind of similar to the TA. You can see a little bit of anatomic variability in some of the anatomy studies out in the literature. So you can have an additional slip that can come off of the tendon if you're following it in short axis down to its insertion. Most commonly, this will go to the medial aspect of the first phalanx, but there are a few other variations reported out in the literature. So overall, as I mentioned before, extensor hallucis longus tendon pathology, not as common as tibialis anterior. There are some reports of it in ultramarathon runners and taekwondo athletes. You can also evaluate for tenosynovitis in this area. Again, pretty uncommon, but patients with rheumatologic conditions can present with that more commonly. This area is more prone to tendon rupture, just given its superficial location. However, that's typically more traumatic in nature than from overuse, but in certain repetitive occupations, you can get a closed tendon rupture. And then if you do see partial tearing in this area, you can do a dynamic scan, having the patient kind of flex and extend their big toe to help delineate the extent of partial tearing, or looking for gapping if you're concerned for a complete tear. And this can be something if you work with a foot and ankle surgeon who would be comfortable with this, can help with surgical planning as well. And also may have seen it in the prior image, but at the level of the EHL in short axis, you can also see the vasculature, which coming down from the leg starts as the distal anterior tibial artery. And then as it passes under the extensor retinaculum over the tibio-talar joint, becomes the dorsalis pedis artery in continuation. And here you can comment on if there's any calcifications or if the artery remains patent, although I would say most of us aren't commenting a ton on or aren't assessing for vascular pathology. And then we also see the deep fibular nerve in this area. So here we see it at about 3 o'clock to the dorsalis pedis artery. Here it appears normal at the level of the tibio-talar joint. There's no focal compression and no fascicular loss. I will say this is, given that it's a smaller nerve and surrounded by a lot of kind of soft tissue, a lot of times it will appear somewhat homogeneously hypoechoic. So that's, just something to be aware of. And typically it can get swollen and, patients can get symptomatic from this because it is at a site of compression. If they have, certain shoe wear that's too tight or wear sandals and things like that. Again, this course is just lateral to the anterior tibial artery and the dorsalis pedis artery, and kind of trajects more lateral as you go distally. And then after we evaluate those two structures, we can continue evaluating the anterior ankle tendon. So the extensor digitorum longus tendon and muscle visualized here, just at the level before it splits into its tendon slips, appears normal. There's no tendinosis or tearing. Again, this is followed up proximally into the distal muscle belly. And then you can follow it as it divides and follow each slip onto its distal insertion onto the lesser toes 2 through 5. One thing to note here is there's something called a Fibularis bursa that can live between the EDL tendon and the talus. So don't confuse that with a ganglion cyst. Just kind of keep in mind the general difference between a ganglion cyst and a bursa. Bursa is less likely to be symptomatic, will tend to be more compressible. Patient won't really complain of pain in this area. And the cysts will have, again, more of a variable location as well. From there, again, can rotate into long axis view of the tendon. Here we see it maintains a nice normal fibular echotexture and remains relatively hyperechoic throughout. There's no tendinosis or tearing, no Doppler, and the distal muscle appearance is normal. And then finally, we move laterally and see the Fibularis Tertius tendon, which is this small tendon structure over here. And again, appears normal. There's no tearing, no thickening, no Doppler flow. One thing that I definitely did maybe the first few times that I scan this area is just be cognizant that it's not another one of the slips of the EDL. The attachment here is down to the dorsal base of the fifth metatarsal, and then scanning more proximally, you can follow a separate muscle belly up into the leg. And then we rotate onto that in long axis, which is seen here. Again, normal tendon structure, no tearing, no thickening, no Doppler. Overall, looks pretty good. And so next we'll cover a few of the other structures in the anterior leg and ankle protocol. These don't have a super smooth transition from a scanning standpoint, but we'll kind of go through them. The sinus tarsi. So this structure commonly evaluated on lateral scans, but also on anterior scans. This is probably easiest to find if you orient yourself either off of the CFL and then the lateral subtalar joint. You'll rotate the transducer about 90 degrees and then translate kind of distally and anteriorly. And then you'll see the kind of characteristic space of the sinus tarsi with the talus and the anterior process of the calcaneus that come into view. This space, contains a variety of different structures. So there's small neurovascular structures, a number of different ligaments that help stabilize the subtalar articular complex, especially during ambulation. And then obviously a lot of adipose and things like that sit in that area. We won't go into the kind of some of the different ligaments in that visualization, but I refer to Dr. Hoffman's lateral ankle injury presentation as he goes into how to view a few of those in that structure there, in that presentation there. So commenting on the appearance here at the sinus tarsi, overall appearance is normal. There's no evidence of hyperemia, no Doppler, and no edema, kind of the adipose structures in that area. Next, we'll look at the anterior inferior tibiofibular ligament, or the AITFL. This is probably easiest to find if you orient off of the ATFL and then rotate the distal end of the transducer cephalad, so the talus will drop off here, and then you'll encounter the bony cortex of the tibia, and then you'll see the ligament, the AITFL, spanning across those two structures. So here there's a normal appearance. There's no evidence of partial tearing or Doppler. And then it's always good to do a stress view here. So this is a more proximal squeeze in this patient, and no evidence of dynamic instability. This tendon remains in good tension. There's no tears that open up and no widening of the joint there. And then lastly, we'll evaluate the superficial fibular nerve. So we'll pick that up here, and then typically pick this up at the level of the mid-leg, scanning distally. And you want to pick it up subfascially and follow the nerve through the exit of the crural fascia and then down into the ankle, where it'll branch into the medial and intermediate dorsal cutaneous nerves. So this video will show it going through the crural fascia, and we'll play it here. Nerve here goes through fascia there and exits at that point. This patient didn't have any symptoms. Let's see if I can pull this up well. Oops. Didn't have any symptoms, but they did have some proximal nerve edema that you see right about there, and then it gets compressed as it leaves the crural fascia, and then once it exits, it has a more normal appearance once again. So always good to do kind of a Tinel at this location to see if you can provoke any neuropathic symptoms. She also wasn't complaining of that and didn't have any tenderness in this area. So more of a benign finding in this case that I guess could potentially lead to future issues. But one thing to note here is there is, again, anatomic variation where the nerve exits the fascia, so it can be a little bit more distal. If you can kind of see this image here, where the nerve comes into better view is where it's exiting the fascia, but this can be a little bit deeper. And those patients are more prone to traction injuries and nerve issues than kind of folks who exit more proximally. And then lastly here, we'll view the SFN branch into the intermediate and dorsal cutaneous nerves. And we'll pick this up here. And this is kind of scanning back and forth at the branching point or division of those two. So they'll kind of split and come back towards each other, mainly for demonstration effect. See here, split there and come back and forth. So the intermediate branch is over here, and the medial dorsal cutaneous branch heads over this way. And those appear normal. There's no focal compression. Didn't do a Tinel down at that level, but that's another thing you can consider, especially if patients having sensory complaints. And then lastly, kind of going through our ultrasound report. So kind of standard format that we use at Iowa, have a referring provider listed, list our facility. Indication was left foot and ankle pain and first toe weakness. We did a complete study using the machines and transducers that I mentioned on the left dorsal foot and ankle. And we compared two radiographs that were obtained previously. So going through each of those, I mentioned a few of these and had text for a few, but the anterior tibio-talar joint did not show any significant degenerative changes, synovial abnormalities, or effusion. The talar dome cartilage is unremarkable, and specifically, there was no evidence of focal cartilage defect. The tibialis anterior tendon muscle appeared normal. There was no tendinosis or tear, no Doppler, and there was normal distal muscle appearance. The extensor hallucis longus tendon and muscle was intact. There was no large tear. At the level of the tibio-talar joint, the tendon is significantly thickened with hypoechoic heterogeneity, spanning a proximal to distal distance of 1.2 centimeters. There is moderate intratendinous Doppler throughout the region, no sheath effusion. The remainder of the tendon, including the distal insertion, is normal distal muscle appearance. Similar to the tibialis anterior, the EDL and Fibularis Tertius were normal with no tendinosis or tear, no Doppler, and normal distal muscle appearance. The deep fibular nerve evaluated at the level of the tibio-talar joint was normal without any focal compression or fascicular loss. The distal anterior tibial and dorsalis pedis artery are normal at the level of the tibio-talar joint and without narrowing or any significant calcifications. The sinus tarsi was normal. There was no edema and no Doppler. The AITFL was normal with no evidence of tearing, no joint widening, or no dynamic instability. And then the superficial fibular nerve was evaluated from the mid-leg and distal to its terminal branches. There was mild nerve compression at the exit of the crural fascia with proximal nerve edema. There was no pain with sonopalpation at this location. The remainder of the nerve, including the intermediate dorsal cutaneous and medial dorsal cutaneous nerves, were normal. And then finishing up with summary, We see sonographic findings consistent with EHL tendinosis at the level of the tibio-talar joint, correlating with pain symptoms. And then I think it is important to note here also that superficial fibular nerve compression with proximal edema at the exit of the crural fascia was seen, but this area did not correlate with symptoms and was not tender to sonopalpation. And the remainder of the exam was unremarkable. Here are my references, and I'd just like to say thank you, Dr. Cruz, who was a huge help, has been a huge help all year, and has been a wonderful teacher in helping me put this talk together and helping me learn how to handle an ultrasound transducer. And then Dr. Hall as well, who's has also been a really big part of learning diagnostic scans and different ultrasound guided procedures. So thanks. I'll take any questions or if anyone has any comments.
All right, thanks, Logan. That was fantastic. Really great images there. I think I just have a couple of comments on the ankle scan. The ankle scan protocol is a great starting place, but certainly, the foot and ankle are really complex. And at least in my experience, there's oftentimes, multiple different things going on at the same time, or at least multiple things that display pathologic findings. And so, as you had mentioned, it's important to correlate, what we're seeing with what the patient is experiencing. And, sometimes that's challenging. And sometimes, we act as sonographers primarily, and sometimes we act as clinicians and sonographers. But I think that's something that we really bring to the table, is making sure that we're correlating clinically with what the patient's experiencing. So, most of our diagnostic scans include some element of a physical examination to make sure that we're kind of on the right page. A couple of things that I'll mention is, you had mentioned that you guys didn't really image the inferior or superior extensor retinaculi. Looking at your image, especially when you were showing your EHL pathology image, you can, pretty clearly see the retinaculum running over the top there. And so I oftentimes will, similar to you, say like, I didn't maybe formally image the entire thing and the roots, over towards the sinus tarsi and then medially. But you are typically looking at it if you're scanning through the anterior ankle. So just, paying attention to like, is it thickened or anything like that in that area is helpful. As far as, the extensor tendons go, certainly the EHL is not a very common one to see pathology. I'll say the thing I see pretty commonly around the EHL is in the setting of like anterior tib tendinosis. I think a lot of people overactivate their EHL. And so they get kind of like a tenosynovial fusion, tenosynovitis picture without tendinopathy. And so just knowing that, if you see that sort of picture and you don't see the tendon swelling like you demonstrated with fiber disorganization, make sure you're thinking about other potential etiologies that are overactivating that EHL. As far as the midfoot goes, I would say, I almost always include at least a brief kind of scan through the midfoot joints. So I want to look at, the talonavicular, navicular cuneiform, tarsometatarsal joints, Lis franc, and kind of just make sure I'm not missing something going through that area, because every now and then you'll see people with spurring from those joints that will, maybe create like a abrasive sort of surface for the tendons overlying. And so just make sure that you're looking for kind of secondary causes in that area. And then the last thing I'll say is the superficial fibular nerve. I'll say personally, I find it challenging because very frequently there is a bit of a conformational change as it goes from the deep compartment, or from deep to the retinaculum or the crural fascia to superficial. And so sometimes you see that focal swelling. And I think really what you mentioned is kind of pushing on that area and saying, does this recreate your typical symptoms, is a really important thing, because there frequently is a little bit of pathologic sort of appearance to that area. And sometimes it's not clear, what of this is normal, normal swelling as the nerve changes course. And, that's something that ultrasound is susceptible to, is artifact when things change directions versus pathology. And so really, pushing on that area is pretty helpful. Anyone else have any thoughts or comments or questions?
Nice job, Logan. I don't have any real comments. Obviously, I'm a bit biased because this may or may not have been a patient of mine. But I think, Logan, you did a really nice job presenting that and hit on all the important points. And the structure of the presentation was excellent. And this is exactly what Brennan and I and Doug have wanted with this case series. So really nice job. I guess only 2 comments maybe on nerve pathology, not really on scanning protocol. You made the comment about deep fibular nerve compression down at the foot from certain shoe wear and sandals. It can also get compressed under the EDB muscle or tendon. I've had a couple cases of that, so that's just something else to look for down there. And then with the superficial fibular nerve, so similar to the tibial nerve, which is highly anatomically variable in terms of its branching pattern. The more you scan the superficial fibular nerve, there's actually a fair amount of variation and variability in terms of how that nerve splits. So we typically think of the SFN coming out of the crural fascia, continuing distally, and then somewhere around the level of tibio-talar, just bifurcating into the medial and intermediate dorsal cutaneous nerves, but that's certainly not always the case. I'm just thinking of a patient from yesterday who way approximately in the leg, the medial dorsocutaneous nerve popped through the fascia, where the intermediate dorsocutaneous component continued distally under the fascia for about 4 or 5 centimeters and then popped out. So again, just a lot of variability, something to keep in mind because that can trip you up if you are doing any diagnostics or even diagnostic injections in the area. But yeah, that's all I have. Good job, Logan.
All right.
Thanks.
Fantastic. So that'll be it for today. With AMSSM being next week, we'll be taking, I think, a 3-week break, and we'll be back on May 12th for our next case. And so hope to see you all at AMSSM. Come introduce yourself if we haven't met yet. All right. Thanks, everyone. Have a good weekend.